So good morning, everybody. I'm Dr. Mukherjee from Heart Center in Karlsruhe in Germany, and today my topic is going to be LVAD for heart failure. I have no financial disclosures. The objectives and the agenda for today is going to be briefly describing the patient selection, what are the different SS devices presently on the market and how they are used, and we have to have a little bit of detailed discussion on the pre, intra, and post-operative assessment of LVADs, and obviously the complications and limitations of LVADs. So if you define a refractory heart failure, first of all, you have to understand that the patients have severe symptoms. They're all in the NEHA classification of 3 to 4, and they've impaired functional capacity in spite of their optical medical therapy. So they have episodes of clinical signs of, their fluid retention and peripheral hypoperfusion. They are presently in severe cardiac dysfunction, and some of them are in systemic organic injury. Going by the American Journal of Transplantation, the recent data says that there has been an increase in the implantation of the VADs because of the absence of the heart for transplantation. So the organ absence and the lack of organs is presently a big issue, and that's why the incidence of SS device are on the rise. So who needs basically a mechanical circulatory support? They're mostly in the stage C or D, or you can see they're mostly in the NEHA 3B and greater. They have either refractory heart symptoms, or they're on and off from the hospital with current or prior symptoms. So they are basically those people who really in the stage 3 structural heart disease with refractory symptoms are in the need of MCS. So going by the Intermax scores, if you go for long-term LVADs, they are the patients who have been frequent flyers. They are on and off because of their symptoms in the hospitals, or more or less they are housebound, and sometimes in the phases of the life they will be stable, but they are the ones who require early intervention for SS device. The short-term LVADs are the Intermax classes 1 and 2. So there's a registry for mechanical assisted circulatory support, and they said the 1 and 2 are going to benefit, those who have acute episodes, and they really benefit from short-term LVADs. So going by the present things and the SS devices on the market, the ones which are routinely employed in the Europe and Asia, and also in US, are the HeartMate 3, the Heartware HVAD from Medtronic, and the new kid on the block is the Reliant Heart. And the advantage of a Reliant Heart is they have this presently that's certified in EU, in CE. In Europe it has been certified, but in US it's on clinical trial. They have something called the Liberty system in 2018, which was they have what is known as TET technology. That's the transcutaneous energy transfer. And if you have this heart device assisted with the heart assist number 5, they are remotely controlled, and because they are interventricularly placed, there are no chances of driveline infection. So that's the biggest advantage with the Reliant Heart. So this is a checklist which I would advise you to go into details. The checklist, I'm going to go into the next slides, which is going to be basically concentrating on a pre, post, and intraoperative implantation of the SS device. First of all, what you have to know that there may be patients who come with shunts, either intraarterial or intraventricular, and these PFOs may be unmasked after LVAD activation, and that is probably too late to go for this therapy or intervention, because they may likely to cause the shunts, and the patient may have a hemodynamic issue in the intraoperative room. If you go by the LV assessment, the cutoff is left ventricular diastolic diameter. You have to measure it in end diastole, and the internal diameter, if it's less than 36 millimeters, it's advisable that a LVAD can be implanted. And if you have more, then they're associated with increased morbidity and mortality rates. What has to be next ruled out is your pre-implantation is the presence of thrombus, because LA thrombus and LV thrombus has to be addressed to, and they need to be intraoperatively addressed before an SS device is implanted. If you have a valve regurgitation, obviously the Trials show that if you have a mitral regurgitation, they're likely to decrease after an SS device implantation. But if you have a severe AR and tricuspid regurgitation, then obviously needs to be addressed intraoperatively, and it's not so seldom that you have to actually see a patient with LVAD getting an aortic valve replacement in the same operative setting. So that's something you have to keep in mind. And if it's a stenosis valve, obviously it needs to be replaced during the SS device implantation. What you have to also rule out is the presence of aortic disease, which I am seeing in the right side. Obviously, if you see aortic dissection, it's not the right candidate for an SS device implantation. Obviously, the other issues are atherosclerotic plaques, and that can be ruled out preoperatively by doing an echo. An aortic aneurysm is something which needs to be addressed if at all an SS device is required in these patients. You have to also rule out endocarditis, because endocarditis is obviously a septic focus in the body and needs to be addressed preoperatively. So coming into the intraop monitoring during the implantation. So the intraop monitoring can show that actually you have a LV apex. By doing a palpation, you can actually see where the apex is with the surgeon's finger. And once the cannula is in, you can actually see by the movement of the cannula that whether either through the apex needle placement or palpation, you can see where exactly the apex of the ventricle is. And it's a nice way to do it by 3D guidance to see where the ventricle where the apex has been punctured in the middle of the ventricle, the central localization of the apex. The second thing, what you have to understand, that if you are in direct contact with the cannula, either with the interventricular septum or in the wall, that can have disastrous complications, intraoperatively. So it's best you do it through TE guidance, and with TE guidance, you are almost sure that you have optimal placement of the inflow cannula of the inflow cannula of the SS device. So if you are coming out of the pump, first of all, rule out the presence of air in the left ventricle, the inflow cannula, and the ascending aorta, because this is something which you have to keep in mind, that before you are off bypass, this has to be addressed before SS device takes its, you're out of the bypass and the SS device is taken over the hemodynamics. The inflow cannula, what you have to see is you measure your PW Doppler and pulse wave. The max velocity should be less than 2 meters per second. And if you have a low velocity, you have to be slightly pulse type pattern of flow. And obviously it has to be unidirectional laminar flow from ventricle to the inflow cannula. So these are the things you have to keep in mind while doing the assessment of the inflow cannula. Going by the assessment of the outflow cannula, you have to see that you're connected to the ascending aorta. The flow pattern is very, very similar to the inflow cannula. It's unidirectional laminar flow. And again, the pulse wave Doppler should show a velocity maximum less than 2 meters per second. That means your hemodynamically, the inflow and the outflow cannula requirements are more or less same, where the velocity of max is less than 2 meters per second. So this is again the second checklist which you need to have before LVAD activation. And if you go by the checklist, more or less, I have shown it in the previous slides, how you go and monitor these. What's important at this point of time is how to assess the LV unloading and the right ventricular function control. This is very, very important, because this is going to lead to the success of the proper assessment of your of the SS device. And then again, if you're going for failure, then obviously the severity of tricuspid regurg is going to come up, and the right ventricular needs to be addressed too. So let's go quickly and briefly into the post-activation of the left ventricular SS device. So post-activation, first of all, if you see the patient, you have to the LA should be really unloaded, and there has to be a good unloading of the left ventricle. And what is important at this point, that the left ventricle or the intraventricular septum is expected to remain neutral. So what happens in this kind of situation where what is the LVAD is unloading, you have basically a decreased tricuspid regurgitation and decreased pulmonary vascular resistance and RV afterload. So this is an ideal situation, and all this leads to an improved RV function, and that means you had been successfully activated the left ventricular assist device, which has led to a proper unloading of the volume status. So what happens in this kind of situation is you have to see is this is actually a situation where you have activated the LVAD, and the LVAD has actually, if you see that the shift is, it's inadequately unloading because the LVAD is basically still of the same size like preoperative. What happens in this kind of a situation is you can see that there is a septal shift where it's the right ventricle is slowly ballooning, and what is because of the flow and of the speed of the left ventricle assist device and suctions, the suction pressure is so high that there's a septal shift towards the left ventricle. And this is suboptimal because this leads to suboptimal LVAD function and may sometimes, because of the septal shift, cause a complete obstruction to the inflow cannula. So these are the three things you have to be really careful. This unloading, whether it's taking place, if there is a septal shift, and if the septal shift is occurring, how to manage it by controlling your knobs on the assist device on the flow as well as on your hemodynamics. So this can be done very well by using an inflow cannula, which you can see if there is an obstruction using the 3D echo. And there is a balance flow, and there's a RPM in the flow meter, which you can adjust to see if there is too much suction on the assist device. And obviously you can maintain it by controlling your pump flow. This is basically where the TE guidance plays a major role during the assist device implantation. The post-implantation period is very important, where this is a triangular situation where you have the pump flow, the RPM, and the inflow cannula, and you have to find the optimal control among these flow patterns. So if all fails, then obviously you have to look on to the evidence of end organ malperfusion. And if you have to optimize the inotropes despite your LVAD flow, then if it is right ventricular is failure and is refractory to medical therapy, then obviously you have to consider an implantation of a second right ventricular assist device. As I said, the complications are more or less limb ischemia, embolization. If you have gone through this is more or less in cases of right ventricle, embolization of the thrombotic material, stroke, infection, hemolysis, bleeding, and you may end up in SIRS or multi-organ dysfunction syndrome, where you have to see that the organs are not getting hypoperfused and leading to failure. So to summarize, the continuous flow devices and the left ventricular assist device are here to stay. They are very small. They can be sometimes intraventricular. They cause less trauma and obviously leads to improved survival among the patient. And the placement requires a multidisciplinary collaboration between the cardiac surgeon, the perfusionist, as well as the anesthetist, who is basically in charge of the hemodynamics and TE guidance. The cost is still an issue because the more sophisticated the assist devices are, that's the cost on the healthcare system, and that's something we needs to be addressed to. Although I know most of the medical companies are trying the best because of the lack of organs to cut down on the cost and availability of the assist device, but this is still proving challenging. So thank you very much for your attention, and we look forward to see you in person sometime in 2022. Thank you.